This is Dr. This is Dr. Shrinivas, Associate Professor, belongs to Radiology Department, SLIMS Hospital, attached to Bihar University. So here now, this session, I am going to talk about pediatric MRI brain. So what is the specialty of MRI in pediatric brain? So usually, pediatric age group, the first 2 years, the development will take place. So the myelination process, maturity, all the development process takes in the first 2 years. No other modality can show you or eliminate the what are all the process that is happening in the brain. So only MRI is the modality which shows the maturation process and what are all the changes that takes place in the development of brain. So now in this topic, we are going to discuss about the normal and abnormal MRI findings. Because the adult MRI brain is different from the pediatric MRI brain signal intensities. Because it takes almost a 2 years process to the parenchymal matter to myelinate and appears like an adult brain. So let us see in this PPT, what are all the normal MRI and abnormal MRI findings? So in the next few minutes, what we are going to talk. So magnetic resonance imaging. What do you mean by magnetic resonance imaging? So the magnetic resonance imaging means it is a specialized imaging technology where we are using no ionizing radiations. Usually in CT and X-rays, we use ionizing radiations. So ionizing radiations are harmful X-rays that penetrate the body and produces images and also produces residual harmful effects. But here in MRI, we use magnetic field. So the physiology or the concept behind the magnetic resonance imaging is there will be a wide bore MRI magnet will be there, and our human body, which is composed of 70% of water and 30% of the other tissues and bony materials, will give you the signal. So the basically the 70% water product, so that is the hydrogen atoms in our body acts like a tiny magnets, and these tiny magnets will resonate in different frequencies. So when we are keeping our human body into the wide bore of the high Tesla MRI, so these tiny atoms, these hydrogen atoms, which acts like a tiny magnet, so resonates in a particular frequency and produces images. And these images are similar to like histopathological images. It will produce resonate in different, these hydrogen atoms in fat, it resonates in different frequency. In bone, it will resonate. In muscle, it will resonate in different frequency. All these things gives different types of signal and which helps in identifying the normal anatomy and pathology of the human diseases. So now we are going to use the same technique, the magnetic resonance imaging technique in myelination, that is the development of pediatric brain, and how it helps in identifying the insult to the brain so that there will be a hypoxic-ischemic encephalopathy or periventricular leukomalacia changes. That is, whenever there is a insult to the brain, there will be decreased blood supply, decreased oxygen, which results in decreased development of the particular area of the bone, which results in softening of the white matter, and also we call it as leukomalacia, and also it goes for encephalopathy. Different types of changes will be there that we call as encephalopathy. So in this session, we are going to see about insights into the maturation processes. What do you mean by maturation process? Usually at birth, a lot of the brain matter, that is, which is made up of neuronal head and axons. The neuronal head comprises gray matter and the axons comprises the white matter. So these white matter axons should get myelinated. So this myelination process, we call it as maturation. So when it is getting myelinated in a fixed pattern along the 2 years, then we call it different types of myelination. And these myelination milestones has to be achieved at particular time. If there is delay, then we call it as hypomyelination. And if it is failed, then we call it as poor myelination. And suppose if there is insult to the brain, and if there is reduced oxygen flow, then we call it as encephalomalacia or hypoxic-ischemic encephalopathy changes. Okay, so this is called the maturation process. So MRI provides us the great insight into the maturation process, how the brain axons is getting myelinated. Then we also should know how to focus because it is all in the maturation process. We don't know how the unmyelinated fibers and myelinated fibers will appear. So we should know what time we are taking MRI, that time whether it is myelinated, how it will appear. So first we have to establish the normality. So then we have to go and pick up the abnormal findings in the brain. As I told you, this is extremely challenging in the first 2 years because the myelination takes place in the first 2 years. Then whatever the changes in the normal appearances and how it gives clue to the true pathologies as well as the important clinical significance behind that we are going to see. So what are the contents in this class? So let us convert these contents into the basic questions, into 5%. So first, let us think about the brain parenchyma. So what are the normal signal intensities within the brain parenchyma? How to diagnose? Suppose if you are able to identify which is normal, abnormal, then you can easily make the diagnosis of HAE or PVM. What do you mean by HAE? As I told you, it is hypoxic-ischemic encephalopathy or PVL. PVL is nothing but periventricular leukomalacia. So HAE, as the name it says, whenever there is reduction in blood flow, reduction in oxygen, hypoxia, there will be a ischemia, and ischemia results in different types of brain signal changes, which is called encephalopathy. So that is HAE, hypoxic ischemic encephalopathy. And PVL, what do you mean by PVL? Periventricular, that means surrounding the ventricular region, whatever the white matter, the leuko means white, malacia means softening. So the white matter goes for softening, that is weakening, so that we call it as periventricular leukomalacia. So these types of HAE and periventricular leukomalacia differs for both term and preterm infants. So term means after 36 weeks born in 37 weeks born infants, and preterm means before 37 weeks born infants. So these insults depends on the duration of time, and the imaging appearance also vary. So next we will going to see the ventriculomegaly. The brain has some cavities inside that we call it as ventricles. So these ventricles are filled with CSF, and the CSF circulation happens between the lateral ventricles through the foramen into the third ventricle and through that other foramens into the fourth ventricle, and it circulates and provides the cushioning effect to the brain. And this CSF flow, when it is obstructed, then we call it as obstructed hydrocephalus, and these ventricles may be dilated due to the extraneous cause, like when there is extraneous weakening of the brain matter, which results in ex-vacuo ventricle dilatation, or sometimes whenever there is some other problems are there, then there may be communicating hydrocephalus also. So we have to identify how the ventricles are there, whether it is normal or abnormal. If it is dilated, whether it is due to the obstructive cause or extraneous cause, or it is due to the some other cause. Okay. Then think about corpus callosum. So the 5 questions. First question we are thinking about normal signal intensities. Then we are dealing with ventriculomegaly. Then corpus callosum. So what is corpus callosum? The third question. So that is the white matter band which connects both the cerebral hemispheres. This connecting band, we call it as corpus callosum. It started developing in the in vitro period, and you have to identify whether it is completely formed or whether it is incompletely formed. If there is complete agenesis of corpus callosum, then the time of insult would be early. And if there is partial corpus callosal agenesis, then it may be in the late stage. So with the development of the corpus callosum, we can identify the time of insult whether it is early or in the late stage. Then think about the cerebral cortex. So you know what is the cortex is made up of. Cortex is made up of all gray matters, that is head of the neurons. So these cerebral cortex, when the brain matter got insulted during the early period, this also gets into different types of developmental malformations. So that we call it as malformations of cortical development. Sometimes pseudo thickening of the cortex also appears like malformation. So that also we have to identify whether it is pseudo thickening or malformations of the cortical development. Then we have to identify the last one is the posterior fossa. Cyst. What is posterior fossa? Posterior fossa is the infratentorial region and it has cerebellum, medulla oblongata, pons, midbrain acid structures. So these structures, when the cyst is present within these structures, we have to identify whether it is associated with normal conditions or abnormal conditions. So we know some of the abnormal conditions where the posterior fossa is enlarged in size and associated with cyst, which is the common one is Dandy-Walker syndrome and the associated syndromes like inferior vermin hypoplasia and sometimes persistent Blake's pouch cyst also can present. Sometimes the normal cisterna, that is the cisterna magna, when it is enlarged in size, that is more than 20 mm, we call it as megacisterna magna. So to identify the normal and abnormal structures, first identify the normal signal intensity of the brain parenchyma and see the cortex whether it is formed properly. Then check the ventricular cavities whether it is normal or abnormally enlarged in size. Then check the connector band, that is the corpus callosum, whether it is completely formed or any insult is there. Then look for the posterior fossa and identify whether there is any cyst. If there is a cyst, then I try to identify whether it is enlarged and associated with any syndromes like Dandy-Walker, inferior vermin hypoplasia, and persistent Blake's pouch. So one by one we will see. Let us go to the first question. What are the normal signal intensities within the brain? So how to identify the normal versus abnormal? Okay. What are the normal signal intensities? How the brain matter is producing signal intensities? That MRI sequences based on the TR and TE values, we are divided into T1 weighted images and T2 weighted images. So T1 weighted images will have long TR and long TE, which is useful in the earlier stages of myelination because all the fat containing materials will appear hyperintense. That means increase in signal in T1 weighted images. So the earlier process of myelination depends on the fat containing materials like cholesterol and galactocerebrosides within the cell membranes. So these particles will appear more in the initial stages. So when it is present more in the initial stages, that is earlier stages of myelination, obviously there will be increase in T1 signal. So whenever there is increase in T1 signal, that is a normal phenomenon of myelination and you should not take it as abnormal. So in later stages, what will happen once the myelination process, there will be a reduction in the water molecules in the brain. So when there is a reduction in brain water molecules, we can see the reduction in T2 weighted image. Just a minute, because of weight problem. So what are the normal signal intensities? As I told you, it is T1 weighted images where there is more cholesterol and galactocerebrosides. There will be increase in T1 signal intensity. As the myelination progresses, there will be a reduction in free brain water, which shows reduction in T2 weighted signal. So let us see the few MRI images. And you can see here the posterior limb of the internal capsule, and you can see here the structures shown here are myelinated at birth in infant. So whichever is showing T1 hyperintense, no, that is the posterior limb of internal capsule, and this is the optic tracts, and here you can see the optic radiation, and this is the perirolanthic cortex, and you can see the superior cerebellar peduncle here, and this is dorsal midbrain. So these are all T1 weighted images, which is myelinated at birth, which is showing hyperintense signal intensities. So you can observe closely the posterior limb of internal capsule, optic tract and optic radiation, and you can see the periodontic cortex and superior cerebral peduncle, all are showing increase in T1 signal intensity. And you can see here, this is the last one which is given is the T2 weighted signal. So the T2 weighted image shows, you can see the hypointense signal. So this is the hypointense signal which is present in the ventrolateral thalami and for lateral posterior putamen. So these landmarks usually lost in case of term hypoxic-ischemic encephalopathy, that we call it as basal ganglia thalamus pattern of the hypoxic-ischemic encephalopathy. So this normal, okay, the T1 weighted sequences, the normal hyperintense signal intensity, and the T2 normal hypointense signal intensity is lost in case of. So this is normal finding. When it is lost, we have to think that that is hypoxic ischemic encephalopathy at a term where there is altered normal signal intensities, and which results in term type, that is term type of that is basal ganglia thalamus type of hypoxic ischemic encephalopathy. So there are two types of hypoxic ischemic encephalopathy which is present, and one is border zone pattern, that is common in preterm, that is vascular shed areas. So that is very common in preterm babies. The other one is, we have seen, no, like normal signal intensities when it is absent, then it is common in term, that is basal ganglia thalamus pattern of the term hypoxic ischemic encephalopathy. Then another one is periventricular leukomalacia. It is milder form of HIE, which is specifically and commonly seen in preterm infants. So it is a subset of hypoxic ischemic encephalopathy, primarily seen in preterm infants. And it shows mainly ventriculopetal vascular pattern. And it mainly affects the vascular border zone around the trigones and posterior horns of the lateral ventricles. The posterior horns of the lateral ventricles, we call it as the peritrigonal region, and these regions get affected in case of periventricular leukomalacia. So let us see what is the common sign that we can pick up in HIE. So the term neonate, so the normally posterior limb of the internal capsule will appear hyperintense in T1 weighted sequence. When it is not there, then we call it as absent posterior limb sign, posterior limb internal capsule sign. That is the common sign of HIE, that is hypoxic ischemic encephalopathy. So you can see the T1 weighted sequence here. You can see the normal hyperintense, that is the brighter area which is seen involving the posterior limb of the internal capsule. And the same thing is you can see here, and this lighter area is absent. It is darker here. So this is called absent posterior limb of the internal capsule sign, which is seen in hypoxic ischemic encephalopathy. Then how the trigonal region will appear? I told you, no, trigonal region is nothing but which is close to the occipital horn of the both lateral ventricles. So this is a trigonal region. Okay. So this trigonal region is nothing but the white matter which is present between the posterior cortex and the occipital horn of the lateral ventricle. So here you can see this trigonal region here, and this is a trigonal region. See, this trigonal region is normal here in this T2 weighted sequence. And if you see here, it shows some altered signal intensity with the weight loss. And this is common in periventricular leukomalacia. So thus you should be able to differentiate the normal peritrigonal. Sorry for the interruption, poor network. Okay. Because of network problem in between the signal losses there. Okay, first like you have to identify the bilateral signal abnormalities within the neonatal brain. So whenever there is bilateral signal abnormalities within neonatal brain, without clinical evidence of hypoxic, you should suspicious the underlying inborn errors of metabolism. So, whenever there is signal abnormalities, don't think everything is hypoxic-ischemic encephalopathy. It may be also seen in inborn errors of metabolism. The common inborn errors of metabolism are Leigh syndrome, Alexander disease, and metachromatic leukodystrophy. Just see this. Um, just see this. This is a finding in Leigh syndrome. So where there is bilateral signal abnormalities in the potamina, caudate head, and you can see in the T2 axial image, ill-defined abnormal T2 signal is also present in the cerebral peduncles. So another common site of involvement of Leigh syndrome. So whenever there is bilateral symmetrical signal intensity changes in the caudate head, putamen, and the whenever there is bilateral abnormal signal intensities involving the potamina and the caudate head, and in T2 weighted images, it is also can also observe the ill-defined abnormal T2 signal within the cerebral peduncles, which is another common site of involvement of Leigh syndrome. Here you can see the symmetrical confluent white matter signal intensities, which is involving the frontal, subcortical, and the subcortical U fibers also. So whenever you are able to see this type of symmetrical confluent signal abnormalities within the cerebral brain matter, that too predominantly involving the frontal lobes, that too especially the involvement of subcortical U fibers, which is seen in frontal lobes. So this abnormal high signal intensity is also noted involving the putamen and caudate heads. These are all the specific findings which is seen in the Alexander disease. So this is what we can identify. That is bilateral symmetrical T2 weighted confluent hyperintense signal intensities within the periventricular and deep white matter. So you can see the sparring of the eucortical fibers. So the sparring of the eucortical fibers and the confluent involvement of the symmetrical signal in abnormalities involving the periventricular and deep white matter is very common in metachromatic leukodystrophy. So far we have seen abnormal signal intensities. That is the first question. So you can easily come to know that abnormal signal intensities. What are the normal signal intensities? So to summarize, the normal signal intensities will appear, that is the normal myelination causes will appear increase in T1 signal, and in the late myelination stages, it is the T2 weighted images which is very helpful, showing reduction in T2 signal, and the normal myelination pattern at the term will show increased hyperintense T1 hyperintense signal intensity involving the posterior limb of internal capsule, optic tract and ophthalmic radiation, periglandic cortex, nasal midbrain. So when you are able to identify this signal loss in the posterior limb of internal capsule, then it is a sign of HIE. So HIE present in the term as basal ganglia thalamus pattern, and in the preterm that is watershed, involves predominantly the watershed area, and periventricular leukomalacia is a subset of leukomalacia which classically involves only the preterm babies and involves only the peritrigonal region adjacent to the posterior horn of lateral ventricles. And don't think only the symmetrical signal, altered signal involvement is only for HAE or PVL. There are certain entities that like mitochondrial disorders which can present with symmetrical hyperintense T1 and T2 signal intensities. The common things are Leigh syndrome and Alexander disease, which is involving the symmetrical confluent hyperintense signal intensities of frontal white matter and subcortical U fibers, and also putamen and caudate. And you can also see in case of metachromatic leukodystrophy, where there is symmetrical confluent white matter hyperintense signal intensities with the sparing of the subcortical U fibers. Okay, we go to the next question. That is ventriculomegaly. So the next question, as I told you, ventricles are nothing but the cavities within the brain filled with CSF. So whenever there is a rapid increase in head circumference, that is enlarged subarachnoid spaces, the ventricles you have to identify whether it is normal or mildly enlarged. So what do you mean by positive? Okay. So what do you mean by because of network problems? So ventriculomegaly. So what do you mean by positive cortical vein sign? So the visualization of bridging cortical veins within the enlarged subarachnoid spaces. It helps in differentiating the external hydrocephalus from subdural fluid collection. So whenever you are able to see the bridging cortical veins within the enlarged subarachnoid spaces, then it is due to the external hydrocephalus, where there is subdural fluid collection compressing these veins and resulting in the compression beam. But here, whenever you are able to see these veins clearly not compressed, then it is not subdural collection. It is the external hydrocephalus, that is nothing but prominent subarachnoid spaces, which is commonly seen in the young age or term babies. So this is the subdural collection. You can see the subdural collection, which is where it is compressing the whole brain and compressing the veins also. The veins are apparently looks smaller in size. So this is called negative cortical sign, which is seen in the subdural collection. Then what do you mean by communicating hydrocephalus? So whenever there is increased intracranial pressure associated with sulcal effacement rather than subarachnoid space enlargement, then it is called as communicating hydrocephalus. So these hydrocephalus, other than the because of parenchymal abnormalities like cerebral atrophy, due to cerebral atrophy also it can present. That we call it as ex-vacuo ventriculomegaly. So this is how you can differentiate external hydrocephalus from enlargement of subarachnoid spaces. And in case of brain atrophy, you have to see the adjacent parenchymal abnormalities. When there is volume loss, you also think about the ex-vacuo phenomenon and resulting in ventriculomegaly. So you can see here there is ventriculomegaly, and you can see here ventricles associated with subarachnoid system. So you can see the axial T2, that is marked ventriculomegaly without subarachnoid space enlargement in patient with communicating hydrocephalus. This child exhibits specifically raised in the ICT pressure pattern on physical examination. So this is how you have to differentiate the marked ventriculomegaly without subarachnoid space enlargement, where there is prominent ventricle with associated with subarachnoid space enlargement. So next we will go to the third question, that is the corpus callosum. So as I told you, corpus callosum is nothing but it's a band of white matter which is connecting both cerebral hemispheres. So the corpus callosum has four main segments. One is rostrum, the other one is genu, the body and splenium. So by 20 weeks, all the components of the corpus callosum are expected to be present at the midline. So it will reach an adult appearance, becomes enlarged in size, and adult size it will come by approximately 9 to 10 months of age. This progress is typically slower in premature infants. So this is about the timeline of corpus callosum, and this is about this diagram illustrates the parts of corpus callosum. As I told you, it has 4 main segments. The anteriormost segment is called rostrum, genu, body, then splenium. So this diagram you can see the R tells you it is rostrum, then genu, then body, and this is the posterior most aspect is called the spleen. So how it appears in MRI? In MRI, you can see the normal appearance of corpus callosum and the abnormal, suppose thinned out corpus callosum or slower down corpus callosum imaging appearance. So this is a normal corpus callosum appearance. So you can see the rostrum, and this is called the genu, and you can see the body of the corpus callosum, and this is splenium of the corpus callosum. So this is a midline sagittal T1 weighted image. Normal 2 shows diffusely thin corpus callosum. The first image shows thin corpus callosum, which is isointense to signal to the cortical gray matter. And you can see the T1 weighted image of a normal 12-month-old infant showing corpus callosum with bulbous enlargements at the genu and the splenium. So this corpus callosum has attained adult appearance and it is now hyper-intense compared to the cortical gray matter. You can see the isthmus of the corpus callosum, which always present like a focal thinning between the posterior body and the splenium. So what do you mean by partial versus complete corpus callosal agencies? So there are 2 types of corpus callosal agencies. Primary, complete, and partial agencies of the corpus callosum will occur whenever there is cells occurring prior to 20 weeks of gestation. On the other hand, there will be a hypoplastic corpus callosum, which denotes the insult after 20 weeks of gestation. So you can see the corpus callosum, which is completely present but complete thinned out corpus callosum, and here you can see the agenesis of the corpus callosum associated with brain matter necrosis and softening. See this. This is a secondary partial corpus callosal agencies, which is due to secondary destruction, and the earlier one is that hypoplastic corpus callosum. So what is primary corpus callosal agencies? In primary corpus callosal agencies, the white matter tracts that normally cross the midline to form the corpus callosum reside along the supromedial wall of the lateral ventricles, giving rise to callosal bundles of flops. We call it as flops bundles. So you can see some other signs also in complete corpus callosal agencies. So one is called the raising car sign, and another one is moose head appearance. So the raising car sign is due to the ventricle appearance because of agenesis of corpus callosum, and you can see here the ventricular orientation like a moose head. This is a moose face and moose head, which is seen in complete corpus callosal agencies. So you can see the parallelly oriented ventricles with the bulbous dilatation of the occipital horns. So this bulbous dilatation of the occipital horns, we call it as colpocephaly, otherwise called as teardrop ventricles. So you can see here this ventricle dilatation, and here the flops bundles, which is giving rise to moose head appearance of the ventricles, which is basically seen in the complete corpus callosal agencies. See the teardrop ventricles, the flops bundles, which is seen medially along the ventricles, and you can see the ventricular dilatation, And this ventricular dilatation, which is occurring specifically in the occipital horn, is called as colpocephaly. So you can see this is a sagittal images of the MRI brain, which shows the complete corpus callosum present, that is a normal, and this is a complete corpus callosal absence, and this is partial corpus callosal agenesis. We are comparing with the tractography, the new advanced imaging technique, where you can find the complete this band, which is denoted in the red color. You can see the complete presence of band in case of normally present corpus callosum, and you can see the complete absence of the red color band, where there is complete corpus callosal agencies is there. And here it is present only in anteriorly, where we can identify the corpus callosal structure, that is rostrum and genu is alone present. The body and posterior aspect is totally absent. So you cannot identify the connecting band fibers, that is the red color fibers in the posterior aspect. Okay. Then we'll go to the fourth question, that is the abnormalities of the cerebral cortex. So which is the normal cortex? How the normal cortex will present, and what do you mean by pseudo thickening? So on T1 weighted images, the non-myelinated white fibers, which is appearing hypointense relative to cortical gray matter, so that it provides a good contrast. So 4 to 8 months of age, gray matter and incompletely myelinated subcortical white matter almost equal in signal intensity. So blurring of gray-white matter junction as well as pseudo thickening of cerebral cortex is common at 4 to 8 months of age. So one should not think that this is abnormal, and you should not think for the malformations of the cortical development. So during this period, the cortical ribbon is better depicted on T2 weighted images. So you can see the poor differentiation of gray-white matter junction, that is the cortical gray-white matter junction at 4 to 8 months age, and when it glows, you can identify clearly. So you should not mistake it as abnormal cortical development. Then abnormal cortical development, that is sometimes it may be focal or diffuse. So when it is focal, we call it as focal cortical dysplasia. How to differentiate from the low-grade glioma? So if you see the micro-lissencephaly, hemimegalencephaly, and focal cortical dysplasias are the range of various spectrum of abnormal cortical malformations, which is seen due to the disturbances in neuronal proliferation. The cortical thickening or the blurred gray-white matter junction can also be seen in these conditions. So how to differentiate FCD from low-grade glioma? So it is often a challenge because you have to identify the location. The frontal lobe location mostly favors the focal cortical dysplasia, while low-grade glioma most commonly seen within the temporal lobe. T2 hyperintense signal seen within a low-grade glioma is often appears better circumscribed when compared to the indistinct hyperintense signals seen in the focal cortical dysplasia. So you can see the focal cortical dysplasia, where you can see the indistinct margins, and particularly the focal, this cortex alone appears abnormally thickened. So this is a classical appearance of the focal cortical dysplasia. Okay, then if the migration process is arrested, this will result in either gray matter heterotopia, which is called as classic Lissencephaly. Lissencephaly is the figure of 8 appearance, and if it is disruption of cortical organization, on the other hand, it will result in polymicrogyria or Cyst-like, which is called as cleft brain. So you can see this figure of 8 appearance of the brain, where there is band heterotopia. You can see the cortical gray matter, white matter, and the abnormal ectopic location of the the gray matter, and smoothing of the brain. Pachygyria, agyria complex. This is absolutely smoothened brain, and this is called Lissencephaly. And the type 2 Lissencephaly present whenever there is a nodular type, and you can see the subcortical heterotrophic gray matter present. So, and what about the abnormalities of cortical gray matter? So, whenever there is left frontoparietal pachygyria, polymicrogyria. So you can identify these flat and curved structures. So axial T2-weighted image shows abnormal gray sulcation pattern and cortical thickening at the left frontoparietal lobes. There is also blurring of the gray-white matter junction. So this is the complex which is seen classically in frontoparietal region, that is pachygyria and polymicrogyria complex. And this is Cystencephaly. So this Cystencephaly, it's always called two types are there, cleft brain. So one type is closed lip Cystencephaly, the another one is open lip Cystencephaly. So closed lip Cystencephaly, you can see here the CSF space from the surface communicating with the ventricle, and it is surrounded by the heterotopia, that is gray heterotopia, gray matter heterotopia. And this is open lip Cystencephaly, where the ventricles directly communicating with the surface of the brain, and you can see the CSF space. And the final one, the last one is posterior fossa cyst. This is the fifth question. So far we have discussed about the brain signal abnormalities, ventricular abnormalities, then about corpus callosum, and the malformations of the cortical developments. So finally, we are going to see about the posterior fossa cyst, when it is normal and when it is abnormal. So when there is enlarged posterior fossa, and you have to think about the common malformations like Dandy-Walker malformation, and this evaluation of posterior fossa include assessment of the posterior fossa volume, the morphology of cerebral vermis, and as well as fourth ventricle brainstem. Silence, please. So think about cerebral vermis. Okay, the cerebral vermis is nothing but the part which is connecting the two cerebral hemispheres. So it has three main portions. One is primary and pre-pyramidal fissures. So the first EGM of the fourth ventricle should be sited just beneath the midpoint of the ventral pons on the sagittal plane, and the posterior margin of the brainstem should be at a straight line. So see the vestigium here, it should be pointed here, and you can see the pre-pyramidal fissures. This is a normal anatomy of the fourth ventricle, and you can see the midline, the three main portions, the primary, pre-pyramidal, and you can see the vestigium of the fourth ventricle beneath the midpoint of the ventral pons, which is seen classically on the sagittal plane. So how to approach these cyst-like malformations? If the vermis is normal, the cyst-like malformation may be either due to megacisterna magna or persistent Blake's pouch cyst. So megacisterna magna is the enlarged cisterna magna, which measures more than 10 mm on mid-sagittal plane. So how to identify? So when vermis is intact, then you have to think whether there is any abnormal inferior opening of the fourth ventricle. If there is any abnormal inferior opening, then think about Blake's pouch. If it is not there, then think about megacisterna magna. So vermis is intact with only enlarged posterior fossa. It's not intact and associated with enlarged posterior fossa. Then think of classic Dandy-Walker malformation. Which is associated with severe vermin hypoplasia and absence of normal vestigium and primary fissure, that we call it as the Tartula lambdoid inversion. And when it is not associated with enlarged posterior fossa, then think of inferior vermin hypoplasia, that is mild vermin hypoplasia with preservation of primary fissure. A primitive vestigial point may be seen, the vestigium may be seen, but it may be primitive in case of inferior vermin hypoplasia. So you can see the classical megacisterna magna here, the sagittal T1 weighted image, see demonstrating cyst-like structure within the posterior fossa, but you can see the normal fourth ventricle with normal vestigium. So here it is inferiorly communicating with the fourth ventricle. So then it is called as persistent plaque spot cyst. So whenever it is communicating with the fourth ventricle, then it is persistent plaque spots, not metacystoma magna. So if the cerebellar vermis is severely hypoplastic and associated with enlarged posterior fossa, the diagnosis is classically, we call it as classic Dandy Walker malformation. And it is always associated with rotated hypoplastic vermis and the torcular inversion, what we call it as torcular lambdoid inversion. So here what I am showing is the Dandy Walker classical imaging appearance of the Dandy Walker malformation, where you can see the enlarged posterior fossa with you can see the lambdoid inversion. See here, this is the lambdoid at the torcular inversion and hypoplastic posterior fossa structures which is attaching here. So this is classical appearance of the posterior fossa malformation, that is classic Dandy Walker variant. Okay, come to the conclusion. So the accurate interpretation of MR studies of the pediatric brain is extremely challenging, especially in the first 2 years of life. As the appearance of the normal brain, it's keep on changing based on the development of the maturation process, that is stage of the myelination pattern. So here we have shown you what are all the changes in normal appearance, so that how the normal signal intensities will appear and how to pick up the abnormal signal intensities. So this is how in this class we are differentiating, like we are able to understand after the end of the class. The take home point is how to differentiate the normal and abnormal structures, and what are all the common abnormal structures that present in term and preterm, how it appears in HAE and preeclampsia, and how in other conditions it present. Thank you. Thanks for your patience.